Okay, so good morning, everybody, and welcome to this call. There may still be a few people joining, but we'll get underway. So welcome to the latest in our series of global breakfast meetings in which we try and introduce our supporters to the work that we do and to the people who do that work around the world. So thank you for giving us your time this morning. We will finish by 9:15, so we won't take up too much of your day and you can rush off to your next Zoom meeting. The purpose of the Global Breakfast meetings, as I say, is to try and connect our supporters with the work that we do out in the field. And this morning we're going to focus particularly on our programme in Cameroon, which is one of the sort of major programs that we run, and a very successful one. Cameroon's in West Africa, very poor country, having quite a number of security difficulties at the moment, with what is sort of effectively a low-level civil war going on. Country divided between English-speaking and French-speaking, so there's still that sort of unfortunate colonial legacy that the country's trying to deal with. But we have with us, or at least I hope we do, he was having some connection problems a minute ago, but Dr. Glenn Mbah, who is our programme coordinator in Cameroon, he's a nurse at the Cameroon Baptist Hospitals and has 11 years experience as a nurse trainer. He also qualified this year for his PhD, so he's now Dr. Glenn Mbah, and in the middle of everything else managed to get married as well. So we're very pleased to welcome Glenn to talk to you to start with. And then we also have with us Rachel Hollis, who is a World Child Cancer Board member and also a nurse advisor for children's cancer at Leeds Children's Hospital, has 30 years experience as a nurse in the UK, is a fellow of the Royal College of Nursing, and is very instrumental in the twinning partnership between Leeds Children's Hospital and the hospitals in Cameroon, which you'll hear more about in a bit. And Rachel's also very active in the International Society for Paediatric Oncologists, and is a leader in her field. So we're delighted to have both Glenn and Rachel with us this morning. We have a sort of fallback strategy that if Glenn can't get into the call, that Rachel has his slides and will speak for him. So let me just see, is Glenn with us at the moment? I'm thinking maybe not. So in the hope that he can get back into us in a minute, can I bring in Rachel to kick us off this morning?
Thank you, John, and thank you for the invitation to talk this morning. And I really hope that Glenn manages to get back in. He was with us briefly a little while ago, but internet connection in Cameroon is a challenge. And unfortunately his internet was unstable, so it looks like he's not with us at the moment. If at any point he joins in, we'll keep an eye on the screen, and Anna or Libby, if you can let me know that he's here, and I'll shut up and pass over to him. But otherwise, as John says, I have got the slides that Glenn had prepared today to talk to you about the programme in Cameroon. Anna's kindly going to share those slides. And I'm going to give Glenn's words, which again, he being a very well prepared young man, has sent yesterday. So the words that I'm going to speak initially will be his words, but I might throw in the odd comment myself. So Anna, would you be able to put up the first slide, please? First of Glenn's slides. Great, thank you. So as John said, Glenn is a children's cancer nurse. He again is a leading children's cancer nurse, not only in Cameroon, but in Africa. He's been part of PSYOP Africa, and internationally he's very active, including in the current WHO Global Initiative for Children's Cancer. But for today, he wishes to present to you how World Child Cancer UK has been supporting the development of services for the care of children with cancer in Cameroon. So if we could have the next slide. As John has said, Cameroon is in Central West Africa. For those who are perhaps a bit less familiar, this is where it is. It's a lower income country with a population of about 27 million, of which 40% are below 15 years old, which is obviously very different to the position in many Western countries, and shows that childhood illnesses, including cancer, will be prevalent in that country. 30% of the population live on less than $2 a day. Next slide, please, Libby. Anna, thank you. This is a map of Cameroon, which shows the 10 different regions of the country and the location of dedicated paediatric oncology units. There are two main centres, which are where there are trained oncologists leading the care. This is Mbingo Baptist Hospital, you can see up in the northwest, and the Chantal Beer Foundation Hospital in Yaoundé. As John has said, Cameroon is divided into French and English-speaking parts. Yaoundé is in the French-speaking part of Cameroon, and Mbingo is in the northwest. And the four centres that have the grey boxes there, these are the centres run by the Baptist Convention, and where the programme started, and where our twinning partnership between Cameroon and Leeds is primarily based. So the next slide, please. So the programme began in Banso Baptist Hospital. This is a picture of the hospital run by the Cameroon Baptist Convention Health Service. And World Child Cancer came into Cameroon through a collaboration with the CBC Health Services. And the Children's Cancer Programme had actually started back in 2003, when a treatment programme was established for children with Burkitt's lymphoma. And that was the most common cancer, or the one that was diagnosed the most. So if we could have the next slide, please. So back in 2003, the programme started as a twinning partnership initially with Stellenbosch University in South Africa and Professor Peter Hessling, who was very instrumental in setting up treatment, and the Beryl Thayer Memorial Trust in the UK. And the programme provided free treatment for children with Burkitt lymphoma.
Rachel, hi, sorry to just interrupt you. Just heard that Glenn is here.
Oh, great.
So we'll just make him the presenter, if that's all right, from the
yes,
next bit. Sure.
Brilliant.
Hi, Glenn. Oh.
Hi.
Oh.
Hi, Glenn.
Hello, can you hear me?
Yes.
Yes, we can.
Oh, great. Thank you. Thank you so much for sitting in for me, Rachel. I'm so sorry, everyone, for not being able to connect on time, and I fear my connection is still a bit unstable, but I hope it works.
Okay. Glenn, do you see where we're at?
I would just like to go to the next slide. Yes, so this is a picture of the first patients that were treated for Burkitt lymphoma at Banso Baptist Hospital. Next slide. By 2006, the number of patients at the hospital became too many, and the patients were coming from too far away. And this necessitated the creation of a second center at Bingo Baptist Hospital, which is still in the Northwest region. Next slide. And then in 2007, a third one was created at Baptist Hospital Mutengene in the Southwest region. So this program was led by local general practitioners and nurses who receive remote support from experienced childhood cancer doctors in South Africa. Next slide. And next, much later in 2019, a fourth center was created in Douala, which is the economic capital of Cameroon. So this made the fourth center within the Baptist childhood cancer program. Next slide. In 2011, World Child Cancer was invited to join this training program. The major challenges at that time included the fact that it took very long to obtain confirmed diagnosis for children. Most of the children defaulted and follow-up was not consistent. Childhood cancer care was also largely combined with general pediatrics care at all the centers. There was little psychosocial support for patients and families, and the coordination of services within the entire
Have we lost Glenn again?
I think we might have done. Yeah.
Okay, shall I continue with the double act? So, so I think you can see what the challenges were at the time when World Child Cancer came in to support the program. So, if we go on to the next slide. So, sorry, let me just work out where we were. Okay, could you go on to the next slide? So yeah, so World Child Cancer coming in as partners to join those existing partners. So next slide, Anna, please. So seeing the more support was needed for the treatment of patients, and the programme began providing treatment and care for children with all types of cancer. Initially, it had been Burkitt's lymphoma, but then there were different types of cancer being treated, and the infrastructure has improved, notably with the extension of the paediatric ward at Bingo Baptist Hospital to make a dedicated 10-bedded unit just for children with cancer, and including 2 isolation rooms for patients at particular risk of infection. And I can see that Glenn is back on the call, so I'm going to see if he also is able to take back over again. So Glenn, are you able to speak?
Yes, I am. Can you hear me?
So I think that that's a picture of the ward, and then if we go on to the next slide, Anna, and hopefully Glenn can take over again.
Attached to
Glenn, just checking if you can hear us, because we're not hearing you.
I can hear you.
Okay, we're not hearing. We just. Yeah.
Please. Rachel, please, could you just take over?
Sure. Yeah, will do. So, so this is the ward extension at Mutengane Hospital, which is in the southwest, and an 8-bedded unit was created there with a playroom on the side of that. And then next slide, please, Anna. And one of the great developments at Mbingo, and John and I were both lucky enough to be there when this facility opened, was the construction of a parents' home at Mbingo, which is the hub centre for the programme. And this was designed to host patients and parents who come often from very distant and remote parts of Cameroon as they await treatment appointments at the hospital, or as children, if it's too far for children to go home in between treatments. And this was created with the support of World Child Cancer, and has been a huge benefit to families, having seen it when it opened and been back and seen it at times very full of families who are able to be away from the hospital. So next slide, please. In 2013, an outreach palliative care programme was started, and a nurse, Joel, was trained in paediatric palliative care and provided with a motorbike with which to go to the home of parents with terminal disease to monitor and evaluate those patients and to control their pain and support with other symptom management. So you can see here Joel on his motorbike, and also Joel in a parent's home helping with a dressing change. Next slide, please. A nutrition support programme has also been started at Mbingo, providing families with daily portions of rice, milk, groundnuts and eggs to improve nutrition, really important for children with cancer. And a nutritionist was engaged to provide dietary counselling, to follow up and teach families how to make nutritional meals with locally available foodstuff. And this has been another use of the parents' home. This is the kitchen in the parents' home, where the nutritionist, Happiness, can spend time with families, teaching them how to prepare nutritious families and meals, and to do so safely. Next slide. In 2018, with the support of World Child Cancer, a teacher was hired to provide teaching and activities to the children during their often long hospital stays and in the parent home while they await treatment appointments. Next slide, please. In 2016, World Child Cancer, now I haven't actually noticed, Glenn has said World Child Cancer wooed Leeds Children's Hospital to join the twinning programme, but it was a great privilege for us to join the twinning programme. Next slide, please. And we have been very engaged with the team looking at staff capacity building, but also in advocacy. Next slide. So these are our consultant paediatric oncologist, Dr. Sue Picton, and consultant surgeon, Dr. Rowley Squire. And we have a monthly multidisciplinary meeting online with the local clinical staff. And at that meeting, all new patients that have come to the service are discussed, and diagnostic investigations and treatment options are agreed on. Next slide, please. And that's supported by a local weekly breakfast meeting started for discussion of patient management and follow-up between all the 4 Baptist hospital centres. So the meeting is coordinated from Mbingo, but joined remotely by the nurses from all the other 3 centres. Next slide. One of the main ways that I've been involved is a series of nurse training workshops to support the Cameroon nurses, and this is the great Cameroon nursing team, with formal cancer care training. And next slide, please. Training has also been provided to the multidisciplinary team on how to provide social and emotional support to patients, families, to the nursing team themselves and to their colleagues. And this training has been led by Megan Cruz, who's the psychosocial advisor to World Child Cancer, who you can see in the picture here, with the participants from the first Train the Trainer programme for psychosocial support. And that's been a great achievement over the recent years. Next slide. And then with support from the team in Leeds, the local team started establishing stronger collaboration with the other childhood cancer centres in Cameroon. And there's been a programme at the Chantal Biya Hospital in Yaoundé since 2000, led by an experienced Cameroonian paediatric oncologist, Professor Pondi, and they were delighted with the suggestion to join forces for the benefit of all children with cancer in the country. The World Child Cancer provide support for leukemia drugs for the children being treated in Chantal Biya Hospital as well. And also they've rented a home for patients who have to go to Chantal Biya for treatment for a more advanced leukemia than can be treated at the moment in the Baptist centres. So next slide, please. Next, we began. Sorry, so that's us in Chantal Biya with Professor Pondi. And the next slide. Next, the team began collaborating with a doctor at the Mount Mary Catholic Hospital in Buea, who was managing children with cancer with very limited resources and support. And he now receives support for drugs, support with home-based palliative care and transportation, and also with nutrition for patients. So next slide. And there we are, the team from Leeds and the team from Bingo with Dr. John and the Bishop of Buea. Next slide, please. So by 2018, there was a big group of stakeholders committed to the care of children with cancer, which became the Cameroon Paediatric Oncology Group. The group is made of healthcare professionals, parents, survivors of childhood cancer, state agents and non-governmental organisations and associations involved in the care for children with cancer. And I think this is the annual conference of the Cameroon Paediatric Oncology Group, or CPOG. Next slide. And the group's activities are focused on 3 pillars, very closely aligned to the 4 pillars of World Child Cancer. So communication and education, holistic management, and administration, which includes, importantly, advocacy with the government. Next slide. The Cameroon Paediatric Oncology Group obtained legal status and became the 6th partner in the twinning programme at the Baptist centres. So next slide. And the CPOG quickly engaged the National Committee for the Fight Against Cancer and succeeded in including childhood cancer specific priority actions in the National Strategic Plan for the Fight Against Cancer, which is a really important development. In many countries, children's cancer is not included in national childhood cancer plans. So it's a great achievement to have formal recognition there. Next slide. And in 2019, they obtained formal collaboration status with the Ministry of Health in Cameroon. Again, a really important development. And the next slide. Other remarkable achievements of the, one major achievement of the group is to work together to create greater awareness of childhood cancer among communities, to promote early diagnosis. And the pictures on this slide show celebration of International Childhood Cancer Day, which is in February, in Yaoundé, in Buea, and at Mbingo. And this day is a great opportunity for awareness creation. Next slide. These are some of the other great achievements of the national group, including development of a national protocol for acute lymphoblastic leukemia. That's a really important development for benchmarking results and collaborating to improve survival in that condition. National conference on improving access to essential medication, a national protocol and strategy for retinoblastoma, which is a childhood cancer of the eye, and undertaking a baseline assessment of services and looking at the action plan at the national level. And we hold an annual symposium with the team where we discuss developments of the service. So next slide. When the COVID-19 pandemic struck last year, the Cameroon Twinning Programme had many challenges shared with many other countries. So transportation difficulty for patients, an increased need for food support as many patients that live at a families live at a subsistence level, drug scarcity because borders were closed in Cameroon, increased need for personal protective equipment and hand hygiene to improve infection prevention, and the significant emotional stress on patients, on families, and on staff. So the next slide. World Child Cancer was able, therefore, to mobilise funds to assist with drug procurement, to improve PPE, and that was a really important contribution, to look at hand hygiene supplies, to support staff through training for resilience and infection training. And thanks to these prompt interventions, then care continued uninterrupted across all collaborating centres, which is not the picture that we've seen in some other countries. There was no fall in the number of children with cancer being treated. Now, Glenn was going to finish with a couple of case studies, and I'm just going to check whether he's able to do that, and otherwise I will continue with those with the same slides. Glenn, is your internet any better? I think that's probably a no. So next slide, Anna, we'll just quickly present a couple of cases. So this is Lindy. She was 2 years old in 2012 when her mother noticed a hard swelling in her abdomen. She was brought to Mbingo where a diagnosis of Wilms tumour, a tumour of the kidney, was made. She was treated with chemotherapy, surgery over 8 months. She recovered, and as you see today, she is a happy schoolgirl on her way to school there. Next slide shows us a picture of Bruno, who was diagnosed with Burkitt's lymphoma at Banso Baptist Hospital in 2013, but he'd had several months of illness. One of the challenges in Cameroon is recognition of childhood cancer, and he'd been receiving treatment from a traditional healer, so the disease had progressed to cause partial paralysis in both of his legs. After a year of treatment and follow-up, Bruno was referred to a rehabilitation centre with support of World Child Cancer, and continued receiving care at home from the outreach nurse. And today he's grown into a young man and is a shoe mender in his village. And the next slide. So whilst the team are able to save the lives of many children, there are still, unfortunately, children who fall between the cracks. And at the age of 6 months, Cleve's parents noticed he had a white spot in his left eye. They brought him to a hospital and were told that it wasn't a problem, it's something that would go away. A few months later, the eye became swollen. They went back to the hospital and were given antibiotics, which didn't help. So by the time he was brought to one of our specialised centres, his tumour was at a very advanced stage. He was given treatment to which he responded well, but it later returned, and the team were at that stage able to offer palliative care, so pain and symptom control, and support the family until he sadly died. These cases show how important it is not only to support the provision of quality clinical care by trained personnel, but also to continue educating healthcare providers and the general population on the early signs of cancer. Whether or not a child gets cured of cancer is often dependent on how early they diagnosed. And we need to continue improving skills of the clinical staff to be able to provide that quality life-saving care with limited resources, and to advocate with the government for policies and financing that guarantee sustainable access to the care of children with cancer. That's the end of Glenn's presentation and his words. So if we could stop sharing the screen, and I'll hand back to John.
Thank you very much, Rachel, for doing that. Thank you all of the audience for your patience while we struggle with the connectivity to Africa, which is permanently a challenge. And I'm very sorry that Glenn couldn't be part of it and talk to us today, because I know he was quite keen to do that. We've got a sort of few minutes left. If there are questions or thoughts that people have, if you could use the little yellow hand at the bottom of your screen to indicate that you want to speak, then I can see that you're asking. But let me sort of start this off, Rachel, and just talk about what your impressions of the service in Cameroon were when you did that first visit, and what did you think of it?
So I think our first visit, which I think was 2016, I think, was I had travelled in Africa, but I hadn't worked in Africa. And I think my first impression was initially the dedication and commitment of the team. I had actually met Glenn and Vera, one of the other nurses, previously, but to see the whole team providing care with very limited resources. And I think one of the things that that is difficult when we go out as a team is that we see children who we know we could treat if they were in the UK with the sorts of resources that we have, and not to be able to do that, and to try and find ways of working with the local team to look at what is possible, what is safe to do, was difficult, but has been a really challenging and rewarding part of our partnership. It does look as if we might have Glenn back, John.
Yes, Glenn, do you want to come and say a few words if you're back with us now?
Yes, John, can you hear me?
We can, yes, go ahead. Oh, we've lost you again, I think. Oh dear.
So yeah, so thank you, Rachel, for presenting on my behalf. I will I'll be happy to take.
Okay. Shall we? I think it's probably just a bit beyond us to bring you in properly to this morning, Glenn. So I'm really sorry for that. We do have a kind of weekly call with everybody, and normally Glenn's able to take part. So we are particularly unfortunate this morning, I think. And so Rachel, perhaps if I come back to you and just ask you to say a little bit about how you would see the service in Cameroon developing over the next few years and what the priorities might be. And just a reflection perhaps as well on the challenge. I've always sort of amazed, you know, to hear the story of how we began this programme with no doctors at all qualified there, and Peter Hessling setting it up just with nurses being able to treat them, and yet having quite a bit of success with it. It's not how we would approach it here. No, absolutely, and maybe I'll take that point first, John, and then think about priorities. So I think, you know, there's an incredibly impressive team of nurses in Cameroon, Glenn and some of his colleagues, and you know, even now in Cameroon, you know, there are 2 trained paediatric oncologists in the country. Francine, who's the wonderful doctor who works with the Baptist hospitals, and Prof. Pondy. You know, and that contrasts with in Leeds, we've got sort of 8.5, 9 consultants, you know, just in Leeds. So there was remote support from Professor Hessling, and then the nurses took on a lot of responsibility in terms of managing the treatment protocols that were developed by Professor Hessling. I think, and that's an incredible model, and very humbling to see some of their achievements. I think in terms of some of the priorities, I think improving diagnostic capabilities, particularly as when the programme first started, it was really just looking at one cancer, so Burkitt's lymphoma, but now they're diagnosing a whole range of different cancers, have got increased capacity to do that, but there is still some of the pathology that is very difficult to, for example, with leukemia, treatment is different depending on what type of leukemia there is, and there isn't the ability to make that distinction. So I think improving diagnostic capabilities, I think continuing to work on protocol development. I think nurse training, we've done a lot, but to ensure that there's recognition of that nurse training. And then I think the national work that, you know, particularly Glenn has, you know, led much of that work in collaboration is critical in terms of moving forward services sort of across the country. Thank you, Rachel. We have a question from Kathy Pritchard-Jones. Can we bring Kathy in?
She's just written it in the chat, so I'm happy to read it out.
Go ahead.
Unless Kathy wants to set us up.
Hi, John, can you hear me?
Yes, yes,
okay.
Go ahead.
Well, first I was just saying congratulations to the team in Cameroon. You know, it's great to see the progress in really developing a network of comprehensive childhood cancer services. I'm very impressed, and also congratulations to Glenn on his marriage, which I didn't know about. But I think my question is this, that you have monthly multidisciplinary conversations with the team in Leeds, which I'm sure is very helpful to discuss new cases. And I wondered if Glenn is still online, if you might comment on how, are you starting to develop that communication across the hospitals in Cameroon? You know, a sort of national network of MDTs to discuss difficult cases. Do you think that's a next step way to go?
We are developing MDTs across hospitals.
Sorry, Glenn, I can't hear you. Maybe you could maybe type it or something. Okay, thank you.
And Glenn, maybe if you type the answer in the chat, that might. I think everyone should be able to see that, I think.
Okay. Well, while we do that, we're coming up towards the end of our time now. Sorry, because of the technical difficulties, the question and answer bit has got a little bit squeezed. But I think we should try and finish on time, as we promised to do for everybody. So a huge thank you to Rachel and to Glenn for all their efforts this morning, and very sorry about the frustrations to Glenn of not being able to get into this properly. And a big thank you to I see there's 32 of us on the call at the moment, so big thank you to everybody for giving up time this morning, and for joining us. And I hope, despite the difficulties, you've got a sense of just kind of quite what they are achieving in Cameroon against some quite significant difficulties. I've got to I can't have a call like this and not mention fundraising, so forgive me, but all of this does depend on the generosity of many of you and others who support our programs. So just a kind of plea that if you can help us financially, please do, or if you have people you can talk about us to in your network and try and see if they might be interested, we'd be really grateful. So thank you for that. Glenn, are you here? Say the final word before we finish.
Yes, John, if you can hear me. I just want to say thank you to everyone who committed to attending this session this morning, and just to say thank you for
All right, sorry, Glenn, that's so frustrating for you. But yes, let me echo what you were saying in thanking everyone for attending, and hope you all have a great rest of the day today. So I think we better leave it there and let you all get off. Thank you very much indeed. Have a good morning, everybody. Bye-bye.
Thank you. Bye.